Okay.
Madam,
Madam,
we are
we are
ready.
Can you can you share the document? Okay, just give me a minute. Screen. Screen. Desktop. Share your screen. Later. Share. Ah. Is it visible now?
Not visible, madam.
Not visible? Okay.
No.
एक मिनट आपने शोभन कैन यू शेयर प्लीज
या मैं शेयर कर देता हूँ फिर। ठीक है, जस्ट अ सेकंड।
स्क्रीन पे रहता है सर एक ये આપણે નહીં એ લોકો શેર કરે नहीं देखा स्क्रीन કારણ કે શેર
हो गया?
हाँ हो गया ओके
चलिए, मुझे यहाँ से करना पड़ेगा फिर।
थैंक यू शुभम
या
okay so once again good evening everyone I'm starting so today we are going to discuss about the osteoporosis conservative management am I audible right now
Yes, madam.
okay thank you so much next slide please so learning objective we are going to discuss about the osteoporosis the basics of bone turnover the risk factors types of osteoporosis what is the importance of DEXA scan possible fracture sites, preventive measures, and of course, conservative measures. So what is osteoporosis? The osteo word mean it is used for the bone. It is the silence disease. The porosis means porosity or of the bone is full of holes. So over a period of time, when there is majority of time there is hormonal influence, the bone becomes porous. So initially the bone density is high in your 20s, 30s, maximum up to 40s. But in later part of the life, under the influence of the hormone, the bone becomes porous, and that's why together porous bone is called osteoporotic bone. So by definition, it is a systemic skeletal disease characterized by the low bone mass and the microarchitecture deterioration of the bone tissue with a consequence increase in bone fragility and susceptibility to the fracture. Commonly, osteoporosis is seen in female. So we call it postmenopausal osteoporosis, that is type 1. So in female, after the menopause, there is lack of estrogen hormone. Eventually, it causes the parathyroid hormone to overstimulate the osteoclast. We will come in the next part of the class. There are two type of mainly bone cells are there. One is the osteoblast and another one is the osteoclast. Osteoblasts are responsible for new bone formation, while osteoclasts are responsible for bone resorption. In short, some breaking down of the bony tissue. So in osteoporosis, there is excessive loss of the trabecular bone. And another type for the osteoporosis, that is age-related osteoporosis, which is more commonly seen in the male after the age of 60, 65. So bone loss happens due to the increased bone turnover. Now, what is increased bone turnover? So basically, bone remodeling, bone formation, destruction, bone formation, destruction, that keeps on happening throughout your entire life period. Initially, in the early phase of your life, till your 30s, till your 40s, the bone turnover or bone reformation, bone formation process is on higher side. But in later part of the life, bone resorption, that is breaking of the bony tissue, is increasing in comparison to the new bone formation. Second is malabsorption, and third is mineral and vitamin deficiency, like vitamin D deficiency or deficiency of the calcium, lead to osteoporosis. Next slide, please. So what are the risk factors for osteoporosis and fracture? So there are two kind of risk factors are there. One is non-modifiable, another one is potentially modifiable. The non-modifiable risk factors are age, female sex, maternal family history of the hip fracture, low birth weight, and disease predisposing to the osteoporosis, like high intake of the steroid, rheumatoid arthritis, some systemic inflammatory disease where you are supposed to take frequent steroid may lead to the early osteoporosis, while potentially modifiable. Okay. So potentially modifiable risk factors are the history of falls, body mass index, drug therapy like corticosteroid use or etc., primary or secondary amenorrhea, early menopause. So if you have early menopause, you can start hormone replacement therapy for some time. Smoking, alcohol, deficiency of calcium and vitamin. So these are the factors which can be modifiable. So in brief, looking at the image, you can say family history. The white race people have less absorption of the vitamin D from the sunlight itself, also leads to deficiency of calcium. Aging, female sex, small stature, fair or pale skin, thigh or obese build also lead to osteoporosis, late menarche and early menopause. Next slide, please. Again, continuation of the risk factors. Whatever we have mentioned, we are just showing it by the picture. Nulliparity, frequent acidosis, low dietary calcium and vitamin D, high caffeine intake, sedentary lifestyle, smoking, excessive alcohol consumption, and liver and kidney disease. So these are the risk factors which are responsible for the osteoporosis. What are the problems with the osteoporosis? Now, this kind of patient frequently we see in our OPD having stooping of the fracture. So normally the patient walk like this, but with aging and osteoporosis, patient bends forward and there is stooping of the, or there is exaggeration of the thoracic scoliosis. So frequent back pain, the height loss and stoop posture, the upper back become curved. You can say the Dowger's hump, broken bone. Sometimes or many a times I have seen in my OPD that when patient come with acute back pain, unable to sit, unable to stand, unable to turn in the bed, they have one old fracture which patient was not knowing. So there is wedging of the fracture and which did not cause any problem to the patient. But when there is second fracture in the vertebra happens, that patient does not able to sit or stand. So it happens with minor injury. What kind of minor injury? Sitting with little force on the sofa or on chair, lifting something very small weight, 5-10 kg lifting causes acute back pain or some spasm. So this kind of small minor injury also causes fracture. and it leads to very severe back pain where patient is not able to sit, stand, walk, and they are confined to the bed. The most common site, particularly in the females, are spine. It may be dorsal spine, it may be lumbar spine. In my particularly practice, I have seen more commonly is D11, D12, L1, L2, and hip joint fracture. So again, hip joint fracture is also, but majority of time with hip joint fracture, there is always history of fall on the ground. While in spine fracture, some forceful sitting or some weightlifting also causes fracture or wedging of the vertebra. Next slide, please. So as I said, you can see a very nice curve here. So till your 40s or till your mid 30s, there is a steep rise in men and women in the bone mass. But after the 40 years of age, there is a significant decline in the bone turnover in which is more common. Bone osteoclastic activity increases and the fracture threshold is also increases in female due to decrease in estrogen, while compared to male, that estrogen level is not so significant, the fracture risk is significantly reduced. Next slide. So with the aging process, as you can see here, the clinical vertebral fracture, it's high after the age of, so almost all the level till 70 or till 65, 70, almost vertebra and hip, they go parallel. But after the 70 years of age, the chances of hip fracture increases significantly, and ultimately it leads to malunion, non-union, and this patient does not respond to some fixation or some replacement surgeries as well. So what are the investigations for the osteoporosis? So of course, when to start screening, the definite screening. So any patient having back pain after 65 years of age, they need to go for the DEXA scan. All postmenopausal which are less than 65 years of age, but they are having one or more risk factor like short stature, smoking, alcohol, lack of dietary intake of calcium and vitamin D. So they need to go for the screening. Screening includes imaging studies, X-ray, MRI, and DEXA scan. While all postmenopausal women with fracture of the spine, they need to go for screening. Also consider the screening of pre and postmenopausal women with certain disease or condition or taking certain medicine. Here, certain medicine taking, that means majority in form of steroid or corticosteroids. Without any new risk factor, subsequent screening should not be repeated more frequently than every 2 years. And next slide, please. So there are various ways for measuring the bone mineral density. Radiographic absorptionometry based on standard or computer generated X-ray, quantitative computer tomography, ultrasound densitometry, and dual energy X-ray absorptionometry. Commonly, what we are using is DEXA scan. So what is bone mineral density? Bone mineral density is the term used to express the amount of bony tissue, either within the entire skeleton or within the some portion of the skeleton. So there is a measurement. So normally, point minus 1 is the point. Beyond that, we called it, the BMD is beyond -1, we call it normal bone density. If the bone, with the DEXA bone scan, the bone mineral density comes between -1 to -2.5, it is called osteopenia. And the BMD is less than -2.5, we call it T score. If it is less than -2.5, that is called osteoporosis. So for the DEXA scan or measurement of the bone mineral density, what are the common sites are used? So the common sites are lumbar spines, that is L1 to L4, hip joint or hip bone, and wrist or lower part of radius and ulna. So bone mineral density, it accounts for 70% of the bone strength. It is the major, although not the only determinant of the resistance to the fracture. As a child grows, the BMD increases until it reaches a peak mass, which is around at the age of 30 to 35 years. Now, after that, the peak BMD tends to be greater in male and then female. And BMD stays at its peak value for few years until the age-related bone loss changes starts. Next slide. So this is the DEXA scan, DEXA dual energy X-ray absorptionometry. So measure density in the radius, lumbar spine and greater trochanter as we discussed. Mass of the bone mineral in the path of the bone beam divided by the cross-sectional area of the beam, which is expressed as gram per centimeter square. This is something theoretical part. How the report is generated, that we will come to know. So this is age 68 and this is age 75. Two female study has been done. So you can see here the green zone, yellow zone and red zone. So this is one curve has been made for the female of that particular age. We call it Z square. So as we discussed earlier, the DEXA scan, the reading where it comes. So when you measure the reading, the DEXA scan here on this scale, you can see here 1.0, 1.10 and the dot which has measured that comes into the green zone. When this dot comes into the red zone, it is called osteoporosis. And we measure the T-score. Now the T-score is less than minus 2.5. The patient is called osteoporosis. When the T-score is between minus 1 and minus 2.5, one patient is having fracture on the X-ray, that is also called osteoporosis. Next slide, please. So the region of interest, as we discussed, femoral neck, proximal femur, greater trochanter, wards area, which is clinically not so useful. And here you can see the measurement, a square box, which falls into the category of osteopenia. So we take measurement at different site, and from that we take out the average, and that average is put into this box. So entire measurement is done by the machine itself. So WHO T-score definition for the bone mineral density. So you can see clearly above one is the normal bone and lower one is the porous bone. So the normal bone T-score is -1 or above. Osteopenia T-score lower than -1 and greater than -2.5. Osteoporosis T-score -2.5 or less than that. And severe osteoporosis, T-score of -2.5 and less than it, and there is presence of at least one fragility fracture. Next slide, please. Biochemical markers. Normally, we are not going for the biochemical marker. In my personal practice, I have not prescribed any of this biochemical marker. So whenever any patient comes with back pain above 60 years of age, primary investigation of diagnosis is X-ray, LS spine, or sometimes dorsolateral spine. The blood reports which I advise are parathyroid hormone, ionic calcium, vitamin D3, B12, TSH, and of course CBC, RBS, creatine, SGPT will be there. So normally we don't go for this biochemical marker. Next slide. So when to treat? So most important for the osteoporotic compression fractures and patients having severe back pain above 60 years of age, lifestyle changes. So we ask them to do lifestyle changes in the form of avoid sitting on the ground. If the fracture is that, put on this lumbosacral support bed to have some degree of immobilization. And also the National Osteoporotic Foundation has recommended certain pharmacological therapy. particularly for the patients whose T-scores are less than -2 as measured by the central DEXA, regardless of the risk factor, and less than -1.5 if the risk factors are there. Next slide. So treatment of osteoporosis, it's a multimodal approach. So multimodal approach, particularly it starts with diet and nutritional, then avoidance of the risk factors, guarded back strengthening exercise within permission of range of the movement, anti-resorptive agents, and certain special agents. Next slide, please. So what we need to do, so particularly the most important treatment, particularly in the osteoporotic patients or documented osteoporotic patient, we need to ensure the bone formation, improve quality of the life, and reduce the risk of the fracture. And also we need to boost the bone strength. Just a minute. Okay. So it boosts the bone strength. Next slide, please. So particularly non-pharmacological therapy, ideally in my personal practice, I always recommend all the females at least 1000 milligram to 1200 milligram calcium per day. We just need to make sure, sometimes patient may ask you that calcium tablet may lead to stone formation and all that. So there are certain school of thoughts which are saying and publishing that your calcium supplements leads to stone formation, and some are denying that. I always ask my patients that whatever water intake you are having, just double the water intake whenever you are on calcium supplements. So the recommendations by the National Osteoporotic Society, 1200 milligram per day for women ages 50 plus and men ages 71 plus. No, no evidence that taking more than 1200 milligram per day is beneficial. Increasing dietary calcium is the first line of approach. Vitamin D, yes, we need to take 800 to 1000 international unit per day for adults having 50 plus years of the age. Many patients may need more. Regular weight bearing exercise, muscle strengthening exercise, particularly walking, doing Surya Namaskar, some low impact exercise in the form of yoga, also always helpful to the patient. Of course, avoidance of smoking and excessive alcohol and prevention of the fall. So these are some basic dietary and lifestyle modification. Coming to the pharmacological therapy. Now, pharmacological therapy, we need to understand the type of cells in the bone. For us, two cells are very important. One is osteoclast, another one is osteoblast. Osteocytes are the cell which form the basic architecture of the bone. So the bone architecture is formed by the osteocyte, but bone resorption, that is breaking down of the bone, and bone formation, new bone formation is taken by the osteoblast. So as we discussed in early part of the life till 35 of your age, osteoblasts are more active compared to osteoclast. But in later part, when estrogen deficiencies are there, osteoclasts become more active and they lead to bone resorption activity. So basically, osteoclast are the monocyte precursor. They come from the hemopoietic stem cells, converted into the monocyte precursor cells, and under the effect of the rank ligand, they are converted into the osteoclast. Now they come to the bone surface. They take out certain bony tissue and create some raw area on the bony surface. Now what happens? the mesenchymal stromal cells, which are precursors of the osteoblast. So again, they are converted into the osteoblast and they do the remodeling or resurfacing of the bone, which some rough surface which is created by the osteoclast. So they put the cells, and from that they get absorbed into the bony tissue and become osteoclast. Next slide, please. So the most important hormone for the treatment of the osteoporosis is parathyroid hormone. So what does parathyroid hormone do? It has effect at three vital structure. One, it maintains the serum calcium level. How? So it decreases loss of calcium in the urine. It enhances the absorption of calcium from the intestine. So in that way, it maintains the serum calcium level. Now the serum calcium level is maintained. So eventually it will reduce the efflux of calcium from the bony tissue. So in that way, it maintains the level of calcium in the bone. But when this excessive parathyroid hormone is secreted, the all action, it will increase the bony resorption, it will increase the osteoclastic activity, and eventually it will lead to the excessive level of calcium. So many a time it happens that when we investigate the patient, the serum calcium level always comes normal. Why? Because many other tissue need calcium for their performance apart from the bone. So to maintain the normal calcium level in the blood, and you are not taking oral intake, patient is not having oral intake of the calcium medicine, there is insufficient dietary intake of the calcium, there is efflux of calcium from the bone, and eventually it will lose or it will make the bone weak to maintain the increased level, the level of calcium in the blood. Next slide, please. So what happens? Postmenopausal women's osteoporosis, there is excess of rank ligand. So as you can see, the prefusion osteoclast, that is pre-activated macrophages. Now decreased estrogen lead to increased level or excessive level of rank ligand. Now this excessive level of rank ligand causes bind to the osteoclast and they cause excessive release of the osteoclast, which eventually lead to activation of the osteoclast and eventually lead to bone resorption. Next slide, please. So what are the therapeutic options for the osteoporosis? So we need inhibitors of the bone resorption, which reduce the osteoclastic activity, and stimulators of the bone formation, that means which increase the osteoblastic activity. So parathyroid hormone variant, which is teriparatide. So there is a chain of 21 amino acid from the parathyroid hormone. We called it recombinant parathyroid hormone, or we call it teriparatide. Now it acts on the osteoblast and it increases their activity. Same way, intake of vitamin D and metabolites, and strontium rendered, which I have not used personally. While we need to have certain drug which reduce or the bony osteoclastic activity, like bisphosphonate, the oral bisphosphonate, alendronate, etidronate, or risedronate, or nasal calcitonin spray, estrogen and progestin, we call it hormone replacement therapy, denosumab, which is the inhibitor of the rank ligand, and severe SERMs, which is severe estrogen receptor modulators, raloxifene. Next slide, please. So bisphosphonate has been used in practice since many years. I think more than 15-20 years they are in use. The common drugs which I have used in my practice are ibandronate, residronate, and zoledronic acid. They are approved for prevention and treatment of the osteoporotic, including steroid-induced osteoporosis. So bind to the hydroxyapatite at site of active bone reception and inhibit the osteoclast function. Next slide. So there are certain bisphosphonate which need to be taken once a month. So certain kits are available where 30 tablets are for calcium and 1 tablet is for bisphosphonate. So normally this bisphosphonate need to be taken orally. After taking this oral bisphosphonate, we need to sit for around half an hour to 45 minutes. They need to be taken at least empty stomach, and after half an hour to 45 minutes the patient is advised to toothbrush and they need to take any other medicine. Patients are not supposed to lie down after taking this bisphosphonate. They can need to walk or stand or maybe sit for half an hour 45 minutes. Another common bisphosphonate is risedronate, that is 35 milligram once a week. Next slide, please. And the zolentronic acid, it's used once a year. So the advantage are they do not much act on the bone mineral density. There is no significant rise in the bone mineral density, but they decreases fracture risk by 4 to 44%. There is no increased risk of breast, uterine cancer or thromboembolic event, and weekly or monthly dosings are there. While disadvantage, risk of gastrointestinal surgery, high cost therapy, complex dosing instruction. As I said, after taking medicine, patient is supposed to sit for longer time, and they are not supposed to take any other medicine. And they are contraindicated in ESRD. Need to adjust dose according to the creatinine clearance. Next slide. So as I said, first thing in the AM, no food medicine for 30 minutes. Take with almost 200 ml or 1.5 glass of water. Don't lie down for at least 30 minutes. And separate calcium, aluminum, magnesium containing medicine by at least 4 hours. Next slide. Long-term use may lead to atypical femoral fracture and osteonecrosis of the jaw. In my personal practice, I have not seen this kind of patient, but yes, it has been documented in many studies. Next slide. So new generation bisphosphonate. The new generation bisphosphonate is shown to have higher binding affinity to the hydroxyapatite in mineralized bone, and it acts as a stronger inhibitor of the osteoclastic activity. So in patients with metabolic bone disorders, intravenous bisphosphonate are used when patients fail to tolerate oral treatment. So zoledronic acid. It is approved by the US FDA for the treatment of osteoporosis in postmenopausal women. It reduces the incidence of spine fracture by about 70%, with significant reduction at 1 year, hip fracture by around 4%, and non-vertebral fractures by about 25% over a period of 3 months if it is taken consecutively for 3 years. So normally zoledronic acid infusion is done in the hospital setup. We need to watch for the any rhythm disturbances of the heart. It is diluted in 100 ml and it is given at least over 15 to 30 minutes. Next slide. Having great potential, longer duration of the remission, convenient once a year dosing regimen, effective in bone metastasis due to solid tumor, so that is also used, and which is only proven bisphosphonate effective in the treatment of bone metastasis due to prostate and lung cancer. Next slide. Anti-resorptive agents, bisphosphonates. So in conclusion, they reduce osteoclastic activity, reduce the fracture risk, little impact on the bone mineral density, does not significantly increase the bone mineral density, but yes, it of course reduces the fracture risk, most promisingly in vertebra. Low impact on quality of the life. Several precautions need to be followed during administration, and effect on bone resorption persists even after discontinuation. Next slide. So effects of the anti-resorptive agents, healthy human iliac crest biopsy, while osteoporotic human iliac crest biopsy. While current treatment reduce fracture risk and allay bone loss, they are unable to restore bone matrix or architecture, and many patients remain at high risk for the fracture. So adverse effect. So as we discuss, osteonecrosis of the joint, esophageal cancer, atypical femur fracture, renal toxicity, particularly with the oral bisphosphonate, and acute phase reaction, which happens mostly with the first infusion of the zolentronic acid in 42% cases. Next slide, please. Estrogen replacement therapy. To be very honest, normally this hormone replacement therapy should be done in collaboration or in talk with the gynecological doctor, because we also need to consider other risk factors. So it is used to prevent and treat osteoporosis. So far, FDA indication is for the prevention only. It decreases the osteoclast activity. The dose is 0.625 milligram QD or 0.3 milligram, offers bone protection as well. Next slide. So advantages of the estrogen replacement therapy: it increases bone density, that is very minimal, 1 to 5%, while decreases the risk of fracture, that is 25%. It gives relief in the hot flushes, vaginal dryness. It decreases LDL and increases the HDL. Relatively inexpensive. The disadvantage: accelerated bone loss after stopping, increased risk of uterine cancer, increased risk of thromboembolic event, possible increased risk for the breast cancer. The side effects are breast tenderness and breakthrough bleeding, and increased risk for the coronary events in women with known coronary artery disease. Next slide. So selective estrogen receptors modulation, that is SERM, which is used nowadays, that is treatment and prevention of the osteoporosis. It decreases bone resorption. Raloxifene is the drug which is used commonly. Next slide. So again, not much difference in the bone density, but fracture risk is significantly reduced, that is 30%, decreased vertebral fracture. No need for progestin in women with the uterus, and decreases LDL. Regarded as a second-line therapy in younger postmenopausal women with vertebral osteoporosis. Increased risk of thromboembolic event. It does not prevent fracture of other side. It does not treat the postmenopausal symptoms. May increase hot flush and leg cramps, and no effect on LDL or high cost per day supply. Next slide, please. Calcitonin. So this is again very easily available drug and very easy to take by the patient. It classified as an anti-resorptive medication. For some actants, it also help for the treatment for the back pain, also acute back pain or acute vertebral compression fracture. Slight increase in the bone mineral density. Bone turnover markers are decreased. Reduce risk for the vertebral fracture, but no proven benefit for hip or non-vertebral fracture. So basically, the nasal doses are there: 200 international unit in alternate nostrils daily. The dose is single daily, single dose in alternate nostril. There are teriparatide. Now, this is my favorite, the human recombinant parathyroid hormone, 1 to 34. So basically, uh, recombinant parathyroid hormone. So the only amino terminal of the human parathyroid hormone, it contains 1 to 34 amino acid of the human parathyroid hormone. It is the first approved anabolic agent for the treatment of osteoporosis. Bone formation is stimulated more than bone reception. Next slide. So what is the rationale? So it endogenous parathyroid hormone production, that is primary or secondary hyperparathyroid, continuous presence of parathyroid hormone in the serum, increase number and activity of the osteoclast, and increase bone resorption markers, and eventually it leads to hypercalcemia in the blood. While opposite to that, if we are giving pulse therapy, that is daily 20 microgram subcutaneous injection. So there is a pen which contains 30 doses which need to be given subcutaneously, maybe around umbilicus or over the thigh. So that is recombinant parathyroid hormone. So intermittent presence of the RPTH in the serum, so it lead to increased number and activity of the osteoblasts, eventually increase bone formation, increase bone mineral density, healing of fracture and prevention of the fracture. Next slide. So it is the first line of treatment for osteoporosis where there is formation of the new bone with architecture similar to the normal bone. So this is again the image having taken from the iliac crest. So that is teriparatide improves both cortical and the cancellous bones architecture. Next slide. So treatment of postmenopausal woman with osteoporosis at high risk of fracture. Increase of bone mass in men with primary or hypogonadal osteoporosis at high risk for fracture, and treatment of men and women with osteoporosis associated with sustained systemic glucocorticoid therapy and high risk of fracture. So as I said, duration of therapy. So total duration of therapy for this treatment particularly is 24 months in US or 18 months in US. So we can say a person in their lifespan can take this therapy maximum for 2 years. Now, if you are having documented fracture, osteoporotic fracture, minimum 6 months need to be taken continuously. Then take a break of 6 months. Again, you take for the 6 months. So in that way, you can take this drug for maximum 2 years. So the daily dosage is, again, the dose need to be taken every day, same time, 9 a.m., 9 a.m., 10 a.m., 10 a.m. So dose is 20 microgram per day. So if you compare the study, teriparatide versus resitronate in prevention of new fracture, multiple studies has been done. So significantly, teriparatide reduces the risk of fracture in postmenopausal women compared to resitronate. So those who are receiving teriparatide in their postmenopausal period or those who are having already documented osteoporosis, the fracture risk is significantly reduced, and at the same time new bone formation is done. Next slide. So the adverse effects are usually very mild. This is very easily tolerable. Patient may have sometimes leg cramps, dizziness. Long-term effects has not been yet reported. Currently usage limited to only 2 years. And FDA has assigned black box warning because of osteosarcoma finding in animal studies. I have been using this molecule since many years. So far, this has not been observed in my patient. It should not be used at all in young children and adolescents. Next slide. Denosumab. Again, this is latest in the anti-resorptive action. So it's a fully human monoclonal antibody. It has having high affinity and specifically from the human rank ligand. So it attaches the human rank ligand and works as an anti-resorptive agent. So it reduces the activity of the osteoclast. So as you can see here, it get this yellow thing is the denosumab. So this is the rank ligand, which is green in color, and it attaches with this rank ligand and it reduces the activity of the osteoclast. So in that way, the bone resorption is inhibited. Next slide, please. So it is again renal safe. The approved indications are it is used for the postmenopausal osteoporosis by the US FDA approved. So many a times those patients who are not taking teriparatide or hormonal supplements, they are put, or those who are likely to undergo for the osteoporosis or having risk factors for the osteoporosis, they are given this dose. So this is very easy to take. It's a single dose technique in 6 months. So once in 6 months, this dose is recommended. The long-term efficacy is also has been proved. So basically, commonly, it is used for the glucocorticoid-induced osteoporosis. So postmenopausal osteoporosis at high risk of fracture, and also to increase bone mass in men with the osteoporosis. Next slide, please. As I said, 60 milligram every 6 months as a subcutaneous injection. Compared to teriparatide, it is cheaper. The advantage compared to teriparatide is teriparatide need to be taken daily, continuously for 6 months, while this need to be taken once in 6 months. Again, it is subcutaneous, so upper thigh, around umbilicus or upper arm. Also, patient need to take calcium, that is 1000 milligram daily, and at least 500 to 1000 international unit vitamin D daily. Next slide. So certain studies have been demonstrated. Denosumab group have a relative increase of 9.2% in the bone mineral density at the lumbar spine and 6% at the total hip. Next slide. So safe in osteoporosis with renal impairment, no dose adjustment required with stage 4 kidney disease. Renal function has no significant impact on the pharmacokinetic. So nowadays, what is next slide? Next slide. Next slide. So patient previously treated with the denosumab versus zoledronic acid. So denosumab has significantly showed increased BMD than IV zoledronic acid at all sites. So it is safer and easily tolerable. Acute phase reaction is also very less, and it can be given in the OPD setup. Patient comes in the OPD, you can immediately give subcutaneous and patient immediately can go back to the home. Next slide. So the summary, denosumab is a fully human monoclonal antibody which inhibits the activity of rank ligand. It is very safe, good efficacy, safety profile is high for the renal, compliance is good, improves bone mineral density. It is the only anti-resorptive agent which increases bone mineral density significantly at critical site. It is also safe in hyperparathyroid patients. There are certain patients on whom the parathyroid hormone level is high, in which we cannot inject or we cannot give teriparathyroid hormone safely. Denosumab can be given to that patient also. It can also be given in some cancer patient. Next slide. So if you compare teriparatide and denosumab, nowadays the combination therapy works fantastically. I personally give my patients start with those who are having osteoporotic fracture and those who are having parathyroid hormone in normal range. I start with the teriparatide hormone, give them 6-month therapy. Then once the this teriparatide hormone therapy is completed, after 1 month of gap, I give them denosumab injection, and then it need to be taken every 6 months. So that is how it goes. Next slide. Next slide. So pre-planned extension of denosumab and teriparatide administration study, a 24-month study duration of 24 months with switching. So year 1 and 2 teriparatide, and then year 3 and 4 continued with denosumab. Initially 1 and 2 denosumab and then teriparatide and then continued. So basically for year 1 and 2, 6 months you can give teriparatide, then denosumab. After again 6 months, you can give teriparatide for another 6 months and then denosumab, and then it should be continued. So initial 1 or 2 year, we can give the combination therapy, and then in continuation, we can give the denosumab. Next slide. Next slide. So to summarize, limited role for anti-resorptive, combination, marginal increase in the bone mineral density, potential increase in risk or side effect, while anti-resorptive and anabolic combination therapy is very much effective. Denosumab and teriparatide together appears the most promising as of now. When starting teriparatide, consider continuation of the anti-resorptive treatment in those who are at high risk of fracture, particularly at the hip. So combination treatment also is useful when you want rapid onset. So I think that is the end for me, end of the lecture from my side. So as I said, exercise, establish osteoporotic with fracture combination therapy works. We can try conservative therapy for 10-15 days. If patient is not able to resume their normal activity, we can consider the vertebroplasty as well. Dietary supplements should be started in very early age, particularly for the female after 45-50 years of the age, for the male after 55-60 years of age. That is what I do. Avoid risk factor, and education of the patient is very, very important. Okay, Dr. Shovan, thank you very much for supporting me and sharing your screen.
Thank you, ma'am. Very nice lecture.
Yeah. I think it was nicely covered. All the medications that we normally use, all the bisphosphonates, as well as the newer agents like teriparatide and denosumab that are being used regularly in all kinds of osteoporosis, osteoporotic fracture, and the results are also pretty good. In our regular day-to-day practice, we're using this. Still, at many centers where we are seeing that the patients are not affordable enough to for this denosumab as well as teriparatide, we're still going ahead with our older bisphosphonates, which is again good enough.
Yes.
Uh, and I think all parts have been covered properly.
Ma'am, I have a question.
Yes, please.
Yeah, do we need any particular investigation before prescribing teriparatide? Any
Yes,
PTH hormone?
yeah, I always go for see if it is you see the bone is osteoporotic, then majority of time it is documented in the X-ray or MRI. So before prescribing teriparatide, I always go for parathyroid hormone study, thyroid hormone study, free T3, T4, ionic calcium, vitamin D3, and B. Those are the investigations I always go before starting for the teriparatide injection prescription.
If PTH hormone is adequate,
Yeah.
then also we can prescribe teriparatide?
Yes. If it is normal, then only we are supposed to give. If patient is hyperparathyroidism, the drug of choice is denosumab, or you can continue with the bisphosphonates.
Okay. Thank you, ma'am.
Welcome.
Ma'am, there is one more question. Giving teriparatide for 2 years, will it work for a lifetime?
So as I said, only giving teriparatide is not effective. We need to continue with the denosumab. So giving continuously, we are not giving any hormonal supplement, particularly for example, patient is taking teriparatide hormone for 6 months in 2025, then after 6 months of gap we will be giving him in 2026. Then again, after, if patient is doing better, like in my personal practice, I have not given any patient teriparatide hormone for 2 years continuously. I have given for 6 months, and then I am continuing with the denosumab. Unless until any new fracture development or any new osteoporotic fracture is there.
Yeah, normally, whenever there is no osteoporosis, porotic fracture per se, we can switch the drugs like teriparatide and denosumab. That will be a better option than using them at a time, so that it can be used for a longer time rather than using it at a time for 2 years.
Yes.
There is another question from Raghav Panigrahi. Is there any role of vitamin K27 in calcium supplements?
So basically, this kind of different combinations are coming by the pharma company. They do different study, they add different molecules. So in my personal observation, I have not find any major difference. I personally suggest calcium citrate maleate, which easily palatable. Patient do not have any major side effect, along with vitamin D combination, and 1000 to 2000 international unit. That is majority of time enough.
One more thing I want to ask you, as you have mentioned in one of your slides that while using denosumab, is it mandatory that we should add on calcium and vitamin D along with that?
Yes. For any anti-resorptive agent or any anabolic agent, or we need to give calcium. See what happens. This mistake is very common. I have seen here in Gujarat, particularly, that when patient is on hormone injection, hormone supplement therapy or teriparatide, so what they believe that this is calcium injection, and they stop oral intake of the calcium. So this is very common mistake patients are making. So we need to educate. I particularly, when I explain them, I put lot of stress on them that this is not a calcium injection. You need to take calcium medicine with that. This is just an hormonal treatment. So with any agent, whether it is teriparatide, denosumab or bisphosphonate, calcium supplement need to be taken. It's mandatory.
Okay, I don't think there is any questions. It's already been 10:30. So
Once again, sorry, and thank you for being patient, and sorry for this
okay. Is
unfortunate.
there any other questions from
No question,
I
sir.
have no questions. So we can wind up this.
Yeah.
Yes. Thank you, Sohan
Thank you.
sir. Thank you, Palak ma'am.
Thank you, everyone. Pardon?
Goodbye बोला मैडम सभी ने.
Okay. Bye bye. Thank you.